Hi, you guys.
Hello.
Hi. I am just connecting my phone to the computer. And let's start in a minute. How are you guys doing Sunday? Still want to learn, huh?
Yeah, doing great.
That's cool. Thanks for activating me. I was almost like, okay, who's gonna join? Okay, let me share my screen. Contact, share screen. Go ahead. Yes. All right, you can see my screen? We don't have the chatty bunch today. We don't have Shweta. She is really chatty and asks questions and tells everything. So what we have to do is we have to be chatty ourselves. And I want every one of you to talk. And it's like more like a, like when you study together. So, and I want you to tell, I have like a few people over here, how, like, are you all residents or practicing? Starting with Sepide. Am I spelling like Sepide?
Yes. Hi.
Hi.
Yes, I'm a resident, PGY3 at Harbor UCLA.
Oh, cool. Awesome. What about Truck Tran?
Oh, hi. I'm also at Harbor UCLA. I'm BGY4 resident.
Oh, cool. Awesome. Ying?
Hi everyone. I'm PGY2. Actually, I'm co-resident with Nupur. That's why I got introduced to your group. I'm so glad to be able to attend here. Most of time I just be quiet to listen to you guys. Like I'm actually just to try to learn here. I know you guys are very experienced.
No, not at all. I mean, it's not really that. The experienced people that we call here, they are the experienced people. We are just trying to learn. I
mean,
personally am just
Compare
trying
with you guys, I'm still like a
to-
baby age. Thank you for letting me join your group.
Sure, anytime, anytime. Thank you for activating me, and especially to Sepide. She activated me today.
Oh, no.
All right, so let's start with, that's where we stopped, lichen planus. So we are going to start with the lichen planus now. So you see this band-like inflammation over here, and that's the first thing that you would see in a lichen planus. They call Sivati bodies or those what do they call Sivati bodies? I guess it's very hard for me to always see where the Sivati bodies are, but then you see these rete ridges that are coming down. So that's one of the clue as well. And let's read what the lichen planus says. So I have already opened the lichen planus. So classic lichenoid dermatitis, there will be hyperkeratosis, acanthosis, wedge-shaped hypergranulosis. So hypergranulosis will also be there. So I think here we see some hypergranulosis a little bit over here. Sivati cytoid bodies, I don't know how to find them. So if someone of you can tell me, that can teach me, that will be great. Basal says squamitization, so that's flattening of cells. There will be, let me mute, there is someone. Yes, so then parakeratosis is generally absent. If a parakeratosis is present, then think twice before diagnosing lichen planus. Artifactual cleft formation between the epidermis and papillary dermis. The cleft formation, I don't think it's clearly visible in this one between the papillary dermis and the epidermis. Maybe a little bit over here, but it's not visible in this one very well. Melanin pigment with macrophages on the dermis. So there will be a pigment incontinence, and occasional subepidermal bullae can be there, not seen in this current case. Presence of eosinophil will be favoring lichenoid drug reaction. in conventional lichen planus. Then there are other type of lichen planus, atrophic lichen planus and hypertrophic lichen planus, and ulcerative lichen planus. And then there are other types which I'm not going to go in details. So let's see the Sevati bodies that they are showing over here. These kind of bodies, they are the Sevati bodies over here, these ones. So, and then they are saying, all right. And then the hyperplastic epidermis, that's over here, hypertrophic lichen planus, sawtooth rated ridges. So we saw a little bit of sawtoothing in our case as well, but not that great. And then hypergranulosis again. And what else? Mucosal lichen planus. Oh, that's opening this thing. Let's actually see that. No, it doesn't go down. All right, so that's about lichen planus, and that's our case over here. So what we see is that bandloid, like lichenoid inflammation, that's the typical thing. And then we have the sawtoothing of the rated edges again. And Sevati bodies, I don't know. As I said, I am not that good in finding the Sevati bodies. Maybe we can find, yeah, maybe, I don't know. And then, so that's what we learned about lichen planus. Okay. Then coming to the next case, irritation fibroma. So irritation fibroma, we are seeing these all the thickened band of collagen. So that's what the fibroma will be, all the thickened bands of collagen. And let's read about the irritation fibroma. So microscopy here. So non-encapsulated nodular mass. So it looks like this fibroma of the tongue over here, ulcerated irritation fibroma. And over here we see non-encapsulated nodular mass, so similar like this, and then mass composed of fibrous connective tissue with collagen bundles interspersed with fibroblasts, blood vessels, scattered chronic inflammatory cells. Overlying surface of squamous epithelium. So that's what we are seeing over here. Just a second. Sorry about that. So that's what they said. That's the nodular, then it's lined by the squamous epithelium, and then the thick collagen bundles. There can be some inflammatory cells in between, which we are not seeing that prominently, and some blood vessels. So thick blood vessels that can be over here, that are over here. So we are seeing that. So that's irritation fibroma for us, thick nodular. So that typical nodular irritation kind of finding. So that's what I read before you guys were here. So let's read about mucocele. Okay, so let's close the irritation fibroma. Mucocele pathology outlines. So mucocele microscopic description. If removed intact, there will be pseudocyst cavity containing mucin, abundant epithelioid foamy histiocytes, muciphages, neutrophils, and granulation tissue. So it will be more of like this we see in this picture. Pseudocyst containing mucin, epithelioid foamy histiocytes will be there, and muciphages, neutrophils, and granulation tissue. If it is ruptured, then fragments of granulation tissue containing epithelioid foamy histiocytes, so more of granulation tissue with epithelioid foamy histiocytes, neutrophils, may see the mucinous material. So let's see what our case is showing us. So yeah, that's what they were showing. So we see over here, there are some lingual maybe glands. And then we have this mucin-filled nodule, if you may. And then there are these muciphages that they are describing. And that's what a mucocele will look like for us. So that's the squamous epithelium over here. So let's see what they are saying more. Removed salivary gland parenchyma showing obstructive changes. That will be acinar atrophy, ductal dilatation with periductal hyalinization, interstitial lymphoplasmacytic infiltrate, and interstitial fibrosis at late stage. So acinar atrophy, ductal dilatation, salivary gland parenchyma. So we have some here. Maybe some acinar atrophy here. It's hard for me to judge. And then Macy ruptured feeding salivary gland duct with squamous metaplasia, and long-standing lesion organized into fibrosis resembling a fibroepithelial polyp. So there will be fibrosis in the long-standing lesions. And then they are doing some mucin stains over here. So let's see. So this is CD68. Okay, CD68 highlighting those mucinophages. So that's that, epithelial macrophages at the periphery. So we saw this very nicely in this case, that the periphery of the mucocele has this epithelioid macrophages or muciphages, if you may. So that's your mucocele. Let's go further. If you have anything to add, please add if you have seen these cases, and like if you want to just add things that you have seen in your cases, just do that. So granular cell tumor with pseudoepitheliomatic hyperplasia, granular cell. So this all pseudoepitheliomatic hyperplasia we see there. And then we have this nice nodule with granular cytoplasm, very eosinophilic pink cytoplasm. So that's your granular cell tumor. Let's read about granular cell tumor. Pathology outlines. So microscopic description. Poorly defined mass composed of sheets of cells, nest ribbons separated by thick collagenous bands. So we have these thick collagenous bands in between. And then cytological features, cells will be round to polygonal, slightly spindled. So we have these spindle kind of cells in between. And then cell borders can be distinct or show a syncytial pattern. Nuclei range from small and dense to large and vesicular. So ours mostly are like small, like some of them are vesicular over here. And then mild to moderate atypia can be seen. So that is not something that you should be worried about. Abundant eosinophilic cytoplasm with coarse granules. That's your typical granular cell tumor, representing phagolysosome aggregates. Overlying squamous epithelium will have the pseudoepitheliomatic hyperplasia. So we saw that nicely in our case over here, the pseudoepitheliomatic hyperplasia. And then malignant criteria, still debated. So there are two types of criteria. Necrosis, tumor cell spindling, vesicular nuclei with large nucleoli, more than 2 mitosis per 10 hyperfield, high NC ratio, and pleomorphism. So they are giving the scores. And then there is another criteria. So that's necrosis again, more than 2 mitosis per 10 hyperfield. So this is consistent, more than 2 mitosis per 10 hyperfield. And then again, they are giving 0 is equal to benign and more than equal to 1, but they are not giving us how to score these things. So basically, we can remember that necrosis, increased mitosis, spindling is a bad thing, high NC ratio is a bad thing, pleomorphism. And so that's your granular cell tumor.
Can I share one thing?
Yes, please.
From a board's perspective, with the granular cell tumor location is really important, knowing the most common location. And then also, I thought it was interesting that blastomycosis is the other entity where you'll see the pseudoepitheliomatic hyperplasia commonly. Those two.
Got you. Okay, so this kind of pseudoepitheliomatic hyperplasia we'll see in the blastomycosis too. Good picks.
Yeah. And then in practice, that part, the attendings always seem to be very scared of this element and making sure it's not SCC, obviously.
Right, obviously, yeah. That's important, like differentiating the pseudoepitheliomatic hyperplasia from actual SCC. And then the typical maturation pattern and the pink cytoplasm that you start seeing in the SCC is, and then you start seeing the infiltration of the epithelium. So that all those things are going to help you. But over here, you can see that they are more of, there is no pink typical eosinophilic cytoplasm that you're seeing over here. And we don't have those, like desmoplastic response with those, pointy edges and everything. So But and then so another thing that also should be remembered that verrucous carcinoma can have these kind of pushing borders too, but then it will have those verrucoid changes on the top too. So those are the things that will help you.
Yeah.
Okay. Ameloblastoma, we saw it yesterday, but we can see again another case because we don't see it very often. So that's your ameloblastoma. Let's read it again. Repetition is always good. So microscopic description. So within the epithelial islands and cords of conventional ameloblastoma, the cystic epithelial lining of unicystic ameloblastoma, the odontogenic epithelium shows similar changes. So there will be columnar cells with hyperchromatic nuclei at the basal layer, exhibiting peripheral palisading. So let's see. So the palisading that they are talking about is within over here. So you see these palisaded cells. That's what we saw it yesterday. We had a better case yesterday. And then reverse polarization away from the basement membrane. Subnuclear vacuolization. So we saw this nicely subnuclear vacuolization in the previous case, but this case is not that great. Over here, maybe subnuclear vacuolization. This all looks like vacuolar to me too. I mean, I don't know if they are talking about that. Suprabasal cells will lose network-like arrangement, recapitulating stellate reticulum. So we saw that yesterday, the stellate kind of reticulum in these cells. And then seen in the normal odontogenesis, no dentin or enamel formation. And then ameloblastoma, conventional type will show macrocystic change of the tumor islands. And when a limited portion of this phenomena is sampled at initial biopsy, the appearance may suggest an odontogenic cyst. So this is really something that I cannot tell. If someone is better at teaching that, then let's see what they are showing this. So they are showing over here granular cell change, some granularity over here, which is like these typical, what do they call it? Stellate-like cells, they are becoming more granular here. That's what I think is that granular cell change. They are coming to a different, like all those different types of this ameloblastoma, they have all different types, follicular plexiform and the others. I would rather remember the typical type because that's most common, and I'm not a head and neck. If I diagnose a ameloblastoma, I'll be happy. So that's the ameloblastoma for us. Okay. And then odontogenic keratosis. Okay. Pathology outlines. So uniform epithelial lining of 6 to 8 cells. So this epithelial lining of 6 to 8 cells we are seeing over here, squamous line cyst, and lacking the rete ridges. So we don't see a rete ridges over here as well. So they are showing nice pictures here. May have artifactual clefting between the epithelium and the underlying fibroconnective tissue. So there is some clefting that is present over here between the underlying tissue and the squamous epithelium. Epithelium characterized by palisaded hyperchromatic basal cell layer. So that's they are showing nicely over here. There is some palisading that is present, comprised of cuboidal to columnar cells. They have areas of budding growth from the basal cells. Luminal surface have wavy or corrugated parakeratotic epithelial cells. Luminal surface. So maybe over here we'll see more of these wavy parakeratotic cells. Maybe over here. Lumen may contain keratinaceous debris, so that's typical. And so let's see. And then there is a orthokeratosis, a nuclear keratin granular layer. Okay. So let's see what we are seeing over here. Odontogenic keratocyst. So we are seeing this is not so that is not well oriented, but this is what they were talking about. We have this squamous epithelium that is present, and then we have some inflammation in here. But this is maybe more typical. The clefting that they were talking about, we are not seeing that very great, maybe some over here. So we have this kind of clefting in between the epithelium and the underlying fibrous tissue, fibroconnective tissue, and then palisaded basal layer. So that we have over here, the palisaded basal layer. And wavy corrugated parakeratotic epithelial cells. So, I mean, keratinaceous debris and parakeratotic epithelial cells. I mean, there is more fibrosis in this one. Maybe it is more chronic or something. Maybe some keratinaceous debris over here. I'm not sure if that was though. And so we understood like at least what a odontogenic keratocyst will have. Epithelium, there will be clefts in, and between there will be fibroconnective tissue. There will be palisading of the basal layer. So all of that. And then in the chronic cases, it is more of fibrosis, looks like with inflammation and everything. So that's your odontogenic keratocyst. All right. So areas of obscuring inflammation. So again, odontogenic keratocyst. So let's see. So this one is very hard, I would believe. So there is urticaria, a lot of it, and obscuring inflammation, a lot of inflammation in places. We don't have that typical squamous epithelium, but at least we have some over here, maybe some palisading, but that's outside rather than inside. And what else? Yeah, more of fibrous. And I mean, if this kind of case comes to us and they already are thinking of odontogenic like keratosis, then we can say consistent with, or yeah, consistent with clinical impression, but it will be hard. Like it's not a typical, like the case that pathology outlines show. Okay, carotid body paraganglioma. Do you think this kind of learning is effective? I mean, to me, it is helping because at least I'm learning various entities, and that's kind of like interesting as well as fun as well to see the cases along with it. Do you think this is helping the other guys? Come on, speak up.
Yes,
Someone
thank
has
you.
to, someone has to speak. Come on, keep on speaking. This is more of study session. This is not something. See, I am studying with you. I don't know all these things. So
Yes.
carotid body.
Yes.
Go ahead.
In 1 hour, we are learning so many cases. So indeed,
Right, exactly. That's what the point is. Exactly. See, so carotid body paraganglioma. So where the site, definition, essential features, terminology, sites. So it will be head and neck along the parasympathetic nerves near the carotid body and vagus nerve, larynx. So carotid body is the most common site, that's the name. And so let's see the microscopic. Similar to pheochromocytoma, there will be cell ball in appearance. So this nesting kind of appearance that will be present, like we can see over here, nice nestings. Trabecular pattern of cells with prominent vascular cells, so network. So that's very nicely given over here, these vascular networks in between. Cell ball may be obscured by anastomosing bands. Round to oval cells, giant multinucleated cells can be seen. Abundant granular eosinophilic cytoplasm. All right, eosinophilic or basophilic cytoplasm. May have nuclear atypia and vascular invasion, which does not indicate malignancy. May have dysmorphic vessels, melanin-like pigment, that is pigmented paraganglioma. Abundant stroma, osseous metaplasia can be there as well. Intracytoplasmic hyaline globules in the sympathoadrenal paragangliomas. No or rare mitotic figures. So what we learned with this carotid body paraganglioma is there will be a Zellballen appearance. It will look like pheochromocytoma. There will be abundant vascular channels that will be anastomosing, and that might even obscure the Zellballen appearance. And there will be multinucleated giant cells. We see over here nicely the well, I mean, this is more of spindle kind of a morphology over here. But I mean, I thought this picture and that picture is different. No, I don't know. I thought for some reason those are multinucleated giant cells. Anyways, so this cell ball in appearance, and then dysmorphic vessels, melanin-like pigment. They haven't shown over here, but melanin-like pigment or pigmented paraganglioma can be there as well. So let's see our case. So we have this nice Zellbolin-like appearance, like nested pattern, Zellbolin, that's typical of paragangliomas or pheochromocytomas. And then we have these blood channels or anastomosing vascular channels that we are seeing, nice and dilated vessels. And then they were talking about, oh, what is this? There's some mucin as well. Okay, this is nice. And then they were talking about the anastomosing vessels can be too prominent, sometimes obscuring the typical nesting appearance. So over here we see a lot of anastomosing vessels. We can think of or imagine of that they are not like this. They are more of obscuring these areas. And then what else they said? Round oval cells with multinucleated cells. Let's see if we have these multinucleated cells somewhere. I don't know. Maybe over here we have some multinucleated cells. So anyways, this kind of Zellbolin appearance with anastomosing vessels, broadly, we should think of carotid body paraganglioma. Okay.
I don't know the answer to this, but in terms of the differential diagnosis with soft tissue, is like alveolar on that differential at all? Do you know?
So alveolar soft part sarcoma, something like that?
Yeah.
I don't know the answer to that as well. I'm not that great in soft tissue. Someone else might answer that.
Okay. Thank you.
Sure. Does someone has answer to this? Does it happen in the carotid body, the alveolar soft part sarcoma?
So this also happens in the abdomen, the paraganglioma.
Right, right. So that, yeah, that time it can be. All right. Let's read about the alveolar soft part sarcoma then. All right. So let's read the alveolar soft part sarcoma. So the sites, where are the sites? Gross images. So deep soft tissue characterized by well-differentiated cells and nests of cells separated by fibrous stroma. And so they are showing the eye, they are showing the tongue as well, nose and thigh, orbital tumor. So all of these. And then microscopic, they are showing nests of cells. So we do have like some nests over here, but let's read what else. Nests of cells separated by fibrous stroma over here. So nest of cells separated by fibrous stroma. So we also have this alveolar kind of pattern. Cells will be discohesive. So these are all discohesive cells. And then composed of large polygonal cells with granular eosinophilic cytoplasm. So there is this granular eosinophilic cytoplasm with this cohesive cells and the alveolar pattern with the fibrous bands in between. Vesicular nuclei and prominent nucleoli. So yeah, sure. This prominent nucleoli, vesicular nuclei. And then vascular invasion is common, also characterized by rod-shaped crystalloids. Okay. No or rare mitotic figures and minimal pleomorphism. And then they are showing this TFE3 stain that is showing this typical, it looks like it is more of cytoplasmic stain here. And PSD looks like it is staining as well. And let's see what else they are showing. Lobular structure. Oh, okay. Oh, nice. Okay. Loss of cohesion in the cell. Good. Let me saw. And then cytology. That's okay. PS stain will be positive. MyoD1, TFE3. So that's your alveolar soft part sarcoma. Membrane-bound crystals with periodicity of 58 to 100 nanometer cross-grid pattern that we don't need to read the electron microscopy. All right, so at least we know some that it can be a differential. I would think so, yeah, to answer your question. These sites of the carotid body paraganglioma looks like it is more in the carotid body, but yes, the paraganglioma can happen anywhere else too. So again, that can be one of the differentials. So the things that are helping us at least differentiate a little bit, I don't know. I mean, anything can happen. So this looks like that too. Those are more discohesive, I would think so, like these. But again, I don't know all the changes that can happen in a carotid body paraganglioma. So, but the TFE3 strain PAS positivity, that might help us. So TFE3 we can remember for the alveolar subpart sarcoma. All right.
That's good. Thank you.
I don't know if that helped anyways, but at least we learned something, so that's important. All right, metastatic P16 positive oropharyngeal squamous cell carcinoma. So, I mean, the squamous cell carcinoma we know, all right, so we have these tight epithelial clusters with desmoplastic response. So there's nothing special about this case, it's just a metastatic P16 squamous cell carcinoma. Cystic change can happen in a squamous cell carcinoma. That's what they are showing over here. Nice cystic change. So that's something that we can remember. Metastatic squamous cell carcinoma with extranodal extension. So this looks like a lymph node, and there is some extranodal, extra capsular maybe extension, maybe something over here that's going outside the capsule. So that's that. And then Thyroglossal duct cyst. Let's see about Thyroglossal duct cyst. So Thyroglossal duct cyst, obviously it will happen midline, neck, anywhere, and from foramen cecum on the tongue to suprasternal region. And most often they are thyrohyoid. So that's that. So that's the Thyroglossal duct cyst. So there's your Thyroglossal duct, and that's where the cyst happens in the Thyroglossal duct. Okay, anyways. So microscopic description. Type of epithelial lining varies by site. Combinations of the type below can be seen in single cyst. So basically there can be ciliated pseudostratified columnar epithelium in the lower neck, perhaps due to close proximity to upper respiratory tract. Non-keratinizing squamous epithelium in the higher neck. So in the lower neck, there is more of columnar pseudostratified, and then in the higher neck, it is non-keratinizing squamous. Stratified cuboidal at the level of hyoid bone. And then there will be secondary inflammation, especially in the sinus tract. So intense lymphocytic infiltration, admixed with neutrophils if the cyst is infected. And then in the duct wall, there can be, or in the cyst, there can be thyroid follicles. So that's something, so typical epithelial lining, and then inflammation, and then the thyroid follicles. So that's what we read up till now. And the thyroid epithelium may be normal or rarely hyperplastic, or neoplastic epithelium can also be there. Often thyroid tissue can be hidden by inflammation. So that's that. And then mucous salivary gland can be found in the cyst wall, frequently lingual and suprahyoid locations. So that's that. And then there are occasional inclusions of skin adnexal structures, gastric mucosa, cartilage, bone, cholesterol granuloma, all of these. So we read that there will be this typical epithelial lining, which could be either pseudostratified columnar or squamous or cuboidal. And then secondary inflammation with lymphocytic, and then thyroid follicles, which are commonly seen, can be neoplastic as well. And then we saw that there can be mucus type salivary glands and the other structures that can be present. So, okay. So we have this kind of cuboidal epithelium. There is lymphocytic infiltration that they were talking about, columnar type of epithelium. And what else? There's a lot of So thyroid-like follicles they were talking about. I wonder if that's what that one is showing. Yeah, these are more of lingual glands that can be seen. So maybe this, let's see if this is skeletal muscle versus, this looks like more of skeletal muscle to me. Do you think this is, I don't think this is thyroid follicles.
I think it's thyroid. Yeah.
I think it's skeletal muscle. Yeah.
Yeah. So I don't see really a thyroid gland in here, but just a second, huh? Just a second. All right, so what else they were talking about? They were talking about the epithelial lining. They were talking about the secondary inflammation. We saw that. We did not see the thyroid follicle, but they are all only found in 30 to 60% of the cases. So they are not always found, and it is not a mandatory thing. And then we saw the salivary type glands, and that's it. So we have some features of thyroglossal duct cyst. This should be enough for us to say that it is consistent with thyroglossal duct cyst. We have this kind. Go ahead, please.
Yeah, Dr. Gupta, I have a question. This Chuk, what is the difference between the thyroglossal duct with the brachial cyst? Both of them can happen in the neck, and I think the brachial cyst is not midline, but not
Yeah.
sure
So
how to
let's read
differentiate
the
histology.
let's read the difference between branchial cyst as well. So that's a good question. Pathology outlines. So lymphoepithelial cyst, branchial cleft-like cyst. That's a different branchial cleft cyst pathology. Branchial pouch cleft anomalies. So terminology, branchial cleft sinus, true fistula. So I believe that should be a branchial cleft cyst. They might be coming later. So that's what they are saying. PTC mimicking branchial cyst. So we are at the right place. So let's read about it. So again, we'll have the stratified squamous or ciliated columnar epithelium lining. Fibrotic walls, so that's what we see also over here as well. Lymphoid follicles that can be seen resembling a lymph node or tonsil. So this is something that's more prominent over here, more of lymph node kind of lymphoid follicles or tonsils. So that's what over here they are showing prominent lymphoid and sometimes follicle formation as well can be seen. Can be secondarily infected that we saw there as well. Sebaceous mucinous gland we saw there as well. And occasionally found thyroid in thyroid tissue as heterotopic cartilage, thymus, and solid thymus. So that can be seen there as well. And parathyroid gland, thymic tissue, tiny masses of cartilage, tiny glands lined by ciliated cells may be seen in normal thyroid glands. So quite similarity, but the differences is more of prominent lymphoid aggregates and then the location. The clinician would know, they are going to tell us many a times that where the location is, or they are thinking of a thyroglossal duct cyst or the branchial cyst. And all our thing is like, all we have to say is, if we see that epithelial lining with lymphoid infiltrate, sometimes the salivary glands and everything. So sebaceous or mucinous gland, and especially the bronchial cyst. So if we see all of that, we can just say that consistent with whatever they are thinking. Or when we don't know the location, when we don't know what we are dealing with, we can say the differential include a bronchial gland cyst or a thyroglossal duct cyst. I believe that's what the approach can be. Someone can correct me if they have an experience.
Thank you, Dr. Gupta.
Sure. And call me Akanksha, don't call me Dr. Gupta. I just passed out. I am very new. So, all right. So that's that.
Ansha, if the carcinoma is confined to thyroglossal cyst, duct cyst, we need not fill a synoptic for it, according to CAP.
Say again, can you repeat?
If the carcinoma is restricted to thyroglossal duct cyst, we need not fill a synoptic. like CAP protocol, according to CAP
Ah,
protocol.
I see, got you. Okay. That's a good point. All right, got you. All right. If you guys want to read in the back as well, just keep on reading in the back so that we'll keep on learning more and more. Oh, they have the branchial cleft cyst over here. Let's read. So this is what the difference is, this prominent lymphoid infiltrate and follicles formation that they are talking about. So this is what the main difference I found in here. So there's this squamous epithelium or any kind of epithelium that is present as well. And then this prominent lymphoid infiltrate. This is what might help us or something. You see, this looks different than what we saw previous in the thyroglossal duct cyst. There's
Yeah.
a very prominent lymphoid infiltrate. And then we have these follicle formation as well. These. Okay, so that's that. All right, so that was thyroglossal duct cyst and branchial cleft cyst. Then metastatic squamous cell carcinoma, no extranodal extension. We don't need to see that.
And I would like to
Metastatic.
add one more point for extranodal extension. It's 2 millimeter of the size for extranodal extension.
Right. If it is, so if it is 2 millimeter or more, then we call it external extension.
Yes.
Yes. All right. So metastated ciliated NK SCC. So SCC is squamous cell carcinoma. I don't know. Non-keratinizing. Okay. In the oropharynx. So ciliated non-keratinizing squamous cell carcinoma in the oropharynx. So sure, we do. I'm trying to see the cilia. Ciliated, let's say. Okay, anyways, they're showing here. I don't know if they're talking about something ciliated like this, but I can't judge based on what they have. But sure, they have this squamous cell carcinoma there. Okay, that's fine. We can move ahead. So branchial cleft cyst, we saw that. High-grade neuroendocrine carcinoma. So we want to learn neuroendocrine carcinoma along with, so the neuroendocrine carcinoma can be of, carcinoma pathology. Let's read about tumor and then we'll read about the. So this is about pancreas, but can happen anywhere too, like can metastasize as well. So neuroendocrine tumors and neuroendocrine carcinomas. So first is well-differentiated neuroendocrine tumors, and then second is poorly differentiated, that is called as neuroendocrine carcinomas. The neuroendocrine carcinomas can be small cell and the large cell types as well. And so we have organoid structure with solidness, trabeculate, gyri, cords, festoons, scribiform, and anything. Eosinophilic, amphiphilic granular cytoplasm, 5ND granular, and then the nuclei that are salt and pepper, and rich vascular network, amyloid deposition in case of insulinomas, samoma bodies in case of stromatostenomas. So we came to pancreas here, but still we'll see, maybe he'll show us, Dr. Akim may show us, because he's going to show us pancreas on Tuesday. Purely differentiated sheets and nest of atypical cells, which will be pleomorphic, hyperchromatic nuclei, abundant mitotic figures. So these mitotic figures are important. And then the Ki67 is important in these. I hope they give that. So necrosis is another important, often present. And salt pepper will be lost in the poorly differentiated or neuroendocrine carcinomas. So then they can be small cell, which there will be molding and scant cytoplasm, or they can be large cell, in which there is abundant amphiphilic cytoplasm and may also have visible nucleoli. Okay, so so there is more of cribriform pseudoacinar pattern in this one. Organoid patterns they're talking about, and then Ki67, which is helpful. So this one is not that great. I mean, not that high. So that's why we have a neuroendocrine tumor here rather than carcinoma. And then some people say that you should print out this kind of picture and then count in the picture as to how much is the Ki67. I mean, I don't know how many people do that, but I know that some people do that and
Yeah,
they
we
follow.
all do here in
Yeah,
Canada.
yeah, exactly. So spread from duodenal spread from the same pancreatic. Okay, so that's a different spread. And that's a nice trabecular pattern with salt and pepper chromatin. This is very nice. And then the synaptophysin chromogranin, of course, and then the AFIP images, there can be encapsulated growth over here that can present. Microlobules, so that's what Dr. Alsati was also saying about microcarcinoids. And medullary pattern, okay. All right, we got the gist and everything. So high-grade neuroendocrine carcinoma. So let's read our case. So this one is definitely very active, like very aggressive, very ugly looking. The organoid pattern is a little bit still present, but mostly although all those typical like nests and cords and trabeculae are almost lost here. This is more diffuse pattern. And we do have, I mean, they are very vesicular in here, like the salt and pepper might be still there, but it's very obscured with all that ugly looking nuclei. So again, the Ki67 necrosis, mitosis, those are the things that will help you. I mean, for these kind of tumors, not, because this we know, but and then they will be positive for synaptophysin chromogranin. So that's how we know that those are neuroendocrine. But if you have something like this, I mean, your differential is also melanoma. You'll do the S100 stains. Your differential can also be carcinoma. You have to rule out that by cytokeratin A1, A3 as well. And what else? So your differential can be diffuse large B-cell lymphoma here as well. So you'll rule that out by CD45 too. So all of these things should come into your mind when you're seeing some ugly tumor like that, poorly differentiated tumor like that. Okay. Chondrosarcoma. Ooh, okay. All right. So it's a mixed bag of everything here. Looks like bone, soft tissue, everything that can happen in the head and neck. We are reading that. So abundant cartilaginous matrix with chondrocytes embedded in the lacunae and lobular or diffuse growth depending on the grade. Permeation of intertrabecular spaces. There will be varying degree of nuclear increased cellularity, atypia, and mitotic activity. Grade 1, 2, and 3. Grade 1, minimally increased cellularity, nodular growth, and occasional binucleate nuclei. And then grade 2, moderate cellularity. So these grades are based on how the cellularity is. So basically, minimal, moderate, and high cellularity. And the other one is the nuclear binucleate nuclei in the first one, diffuse growth in the 2, and then marked atypia and pleomorphic appearance with mitotic figures in 3. And then myxoid change, chondroid matrix, liquefaction, necrosis may be seen. Formation of nodules and cystic cavities can be seen in secondary peripheral chondrosarcoma. Periosteal chondrosarcoma, grade 1 or 2 tumors seen in external surface of the bone. So periosteal will be more on the external surface of the bone. Cortical invasion, soft tissue extension, and size more than 5 centimeter can be helpful in distinguishing periosteal chondroma. Okay, so they have this grade 1, 2, and 3 over here. So basically, we read that abundant cartilaginous matrix with chondrocytes embedded in the lacuna. So let's see that. So we see the lacuna, and these cells, they are not as atypical looking. So that's typical of, and then myxoid degeneration can be there. Grade 2. So grade 1, they saw, they said binucleated nuclei, which I cannot tell by this lower mark. Grade 2, they said moderate cellularity, diffuse growth pattern. And then grade 3, they said very atypical and pleomorphic appearing. And almost the lacuna is gone as well. And then there can be bone permeation. All right, so again, they are showing the grade 1, 2, and 3. Oh, so they are coming to So this is nice. This cells within the lacuna, like more of chondrocytes that are not very atypical appearing. So that's what grade 1 is. And the grade 2, we are showing this one. So grade 2 is moderate cellularity, and then moderate nuclear TPI and everything. I mean, and then grade 3 should be ugly appearing. And then almost that lacuna is almost gone. That's what I'm seeing over here. And then very pleomorphic, ugly looking. So whenever you are dealing with the chondrosarcoma, you have to see how ugly the nuclei are, how much is the mitotic activity, and that's how you're going to grade. All right. And then the site, because it's bone, so site is important. Most common in the pelvic bone, femur and humerus, and trunk, skull, and facial bones. Periosteal will be in the metaphysis of the long bones, usually distal femur and humerus. Conventional type chondrosarcoma is most common sarcoma arising in the larynx. So that's what they are showing probably over here because we are dealing with head and neck. Ooh, this is not what I was expecting. Okay. Oh, nice. Okay, so just that it is too dark stained, but we have these lacuna and then these cells that are. I mean, I don't think that they are very atypical here. All right. So that's your chondrosarcoma. Maybe a bone and soft tissue specialist can tell us much more about these. Anyone has anything to add? All right, so we can go ahead. Squamous papilloma. So this is something that is easy, and we don't need to read much about it. So I mean, we can still, but squamous papilloma. All right, so squamous papilloma, papillary proliferation of stratified squamous epithelium, stratified, and with variable hyperkeratosis and parakeratosis, and then hyperplasia, mitotic activity restricted to the basal layer or parabasal layer, retention of cellular polarity and normal maturation in the suprabasal layer, finger-like papillary projections exhibiting fibrovascular cores, hyalinization at the tip of the cores, and may be seen occasionally, often pedunculated but may be sessile. Collocytes should not be present. So that's an important point, that collocytes should be rare or absent. No endophytic component. Secondary traumatized squamous papilloma may show spongiosis, leukocyte exocytosis, absence of surface keratinization. Dysplasia, that's important. So dysplasia and squamous papilloma characterized by cytological atypia. Abnormalities typical for the epithelial dysplasia. So if they have a nice picture of dysplasia, they don't. So anyways, so they are having a picture of mitotic activity that is limited to the basal layer. So there's this mitosis maybe, but there should not be mitosis over here. If there is mitosis over here, then we should think about dysplasia and these squamous papillomas. Then, all right, so we don't need to spend a lot of time in squamous papilloma. We know how it looks like. All right, so fibrovascular cores, certified squamous epithelium. This is typical papilloma that you'll see. All right, so that's that. Contact ulcer. So I think we saw the contact ulcer already. That was irritation fibroma. Let's see the contact ulcer. That was also contact fibroma, was it? Contact ulcer. Pathology outlines. Microscopic ulcerated or hyperplastic epithelium, occasionally pseudoepitheliomatic hyperplasia with granulation tissue overlying the granulation tissue. So that's what we are seeing over here, all of this granulation tissue. And pseudoepitheliomatic hyperplasia is not that great in here, but all of this granulation tissue, we can start thinking of contact ulcer. And then they will also tell us that it looks like. But remember this kind of morphology. Okay. That's your contact ulcer for you. Cholesteatoma. So cholesteatoma is basically keratinized debris that you will see. So you know that the epidermal inclusion cyst, they also look like this keratinized debris. And unless they tell you that this is coming from, so if you remember your epidermal inclusion cyst, obviously you must have seen by now. So they also have this kind of lining, and the lining between the epidermal inclusion cyst and the pilar cyst, it differs. So let me show you the pilar cyst if you have not seen a pilar cyst. I mean, most of you must have already seen it though. So this kind of so you see this lining of the pilar cyst, this pilar cyst lining versus epidermal inclusion cyst lining. You can see this kind of, that typical eosinophilic cytoplasm that looks like it's, the frilly eosinophilic cytoplasm. So it both can have the keratinaceous debris, but this typical lining is typical of pilar cyst, and there will be no that kind of eosinophilic frilly material in the epidermal inclusion cyst. But I was coming to, if it is coming from the middle ear, then you are thinking of cholesteatoma. If it is coming from somewhere else, then you're thinking of epidermal inclusion cyst. So unless they tell you that there is a mass in the middle ear, and that's what it is coming from, you don't know whether it is cholesteatoma versus epidermal inclusion cyst. So that's what it will be. So remember this kind of material in the cholesteatoma. Let me read it as well.
Yeah, I have one thing to add for this as well. I think for the pilar cyst, you don't have the granular layer in the
Yeah,
epithelial.
the granular layer, right.
Yeah, and in the epithelial inclusion cyst, you will see the normal layer of the epidermis. Yeah.
Right, exactly. That's a very important point as well. All right, so the keratinized stratified squamous epithelium, that's what we saw, granulation tissue, and then keratin debris. And then chronic inflammatory infiltrate can be there, cholesterol grafts, foreign body, giant cell granulomas, and all of these can be seen in the epidermal inclusion cyst as well. And then external ear canal, cystic mass of keratinized squamous epithelium overlying the bone sequestration. Okay, anyways, so that's your cholesteatoma. Think of epidermal inclusion cyst, you'll remember your cholesteatoma. All right, vocal cord nodule. So let's see. Okay. Pathology outlines is such a treasure. So looks like vocal cord polyp and vocal cord nodule are the same things. So laryngeus nodule and Singer's nodule. So vocal cord polyp will be the same thing. And it will be polyps and nodules are histologically indistinguishable. That's what they are coming to, right? So they are indistinguishable. Polyps tends to be larger. Early stage lesions, there will be myxoid edematous stromal changes, fibroblastic proliferation. Late stages, lesions with stromal hyalinization, telangiectatic blood vessels. And overlying squamous mucosa is usually unremarkable, can show mild reactive atypia. So that's that. So basically we read that there can be myxoid edematous stromal changes, fibroblastic proliferation. There can be hyalinization and telangiectatic blood vessels. So that's what we are seeing over here. We have this kind of myxoid appearance with the stellate cells, stellate-like appearing cells, and this nice myxoid degeneration that is present. So that was one of the features, edematous stromal changes, and then there can be fibroblastic proliferation. So let's see if we have those hyalinized blood vessels. So we do have some blood vessels that are admixed in between, and there is some hyalinization that is present as well. Telangiectatic blood vessels, okay. And then overlying squamous mucosa and unremarkable and may show reactive atypia. So that's your squamous epithelium. So that's your vocal cord nodule or vocal cord polyp. So it will be like this squamous epithelium with the mucinous or fibroblastic material in between and inside. And then that can become more fibroblastic, and then you can have these anastomosing or telangiectatic blood vessels as well. That's your typical vocal cord nodule or vocal cord polyp. Polyp will be bigger than the nodule. That's it. Inverted papilloma. So inverted papilloma, they are saying that they will be pink to tan gray, soft, moderately firm, polypoid growth with convoluted or wrinkled surface. And then exophytic is more often papillary appearance. And all right, so inverted papilloma. Architectural, prominent downward endophytic growth of round to elongated interconnected epithelial nests with smoother outer contour. So more of endophytic growth, smoother outer contour. That's your typical inverted papilloma. And then epithelium is more hyperplastic. So we can see that the epithelium is more hyperplastic here. That will be 5 to 30 layer thickness. Maybe squamous, transitional, or respiratory type, any type of epithelium. Transmigrating neutrophils, neutrophilic microabscesses can be seen. Well, I don't see that very prominent here. And then may be seen, so it's not a necessary finding. Stroma, edema, or chronic inflammation. So we do see that the stroma is kind of edematous here. There is chronic inflammation, so that's what we are seeing here. And seromucinous gland in the lamina propria is commonly decreased or absentia. So we don't see the seromucinous gland that prominent over here. So that's your inverted papilloma for you. That particular. So we have this regular outside border, and it's growing inside. Basically, it's more of inverted, and there is this stromal edema that's present, and then chronic inflammation that can be seen in between. So that's your inverted papilloma. For exophytic papilloma, of course, there will be papillary arrangement, filiform, with delicate fibrovascular core. So that's typical of your exophytic papilloma. Oncocytic may have endophytic, inverted, or exophytic growth pattern. It will be pseudostratified columnar, abundant eosinophilic granular cytoplasm, hyperchromatic nuclear. Okay. And neutrophilic microabscesses can be seen here as well. And there can be malignant transformation, that is carcinoma X sinonasal papilloma. Most common type of carcinoma arising in the sinonasal papilloma is squamous cell carcinoma. And then other types of carcinoma that can be seen can be verrucous carcinoma, mucoepitheliomatic small cell carcinoma, and undifferentiated. All right. So that's your typical inverted papilloma. The outside is kind of regular and it's growing more inside over here with the edematous stroma, which is nice over here too. And then the oncocytic type of papilloma, eosinophilic granular cytoplasm, hyperchromatic uniform nuclei. So that's so oncocytic appearing. All right, and then the malignant transformation can be seen, which is more squamous cell like. This is really, so endophytic pattern can be retained in the malignant transformation as well. Epithelium shows architectural disarray, marked nuclear hyperchromasia, nuclear pleomorphism, and tumor necrosis. Okay, so that's, and then the CK7, CK56, P40 in the squamous lining can be present. We don't do stains in these anyways, so that's that. So that's nice, inverted papilloma. Then oncocytic, good, they have that adjacent to it. So we just saw the picture that they showed as well, and this is so oncocytic appearing as well. The oncocytic can be inverted type or exophytic type. So this looks more of, I don't know, I mean, this looks more of inverted type to me. Could be. Yes, this outline is kind of regular and it's growing inside. So that's that. And then they are talking about the sinonasal undifferentiated carcinoma. So that can happen in the papillomas too. So again, like these undifferentiated carcinomas, you have to do your cytokeratin stains, and they are so poorly or undifferentiated that you don't know unless you do the stains. Okay. Yeah, so it's all like sheets of cells which we don't know what they are, and very poorly or undifferentiated appearing. So this is your exophytic papilloma. So this is more exophytic with papillary structures and the fibrovascular cores inside. And there can be some ATPI in here, which doesn't mean much. But if you see dysplasia, that's something that you have to rule out, and you have to start seeing the mitotic figures as well. All right, so that's that. Melanoma. All right, so again, if you see, I mean, this one is more of spindle cell, but melanoma can be very well, like, again, if you don't do the stains and your panel of the stains, you won't be knowing whether this is melanoma. Sometimes you already have history, so you know that it is metastatic melanoma. All right. Mycetoma. Ooh. Okay. Fungal ball. Okay, fungal ball is a mycetoma. Madura mycosis. Let's see. So fungal Madura mycosis. And so we have this fungal ball over here, this fungal ball. And then they were coming to fungal ball. So this kind of fungal ball, aspergilloma. Okay. So we have these nice fungi over here. That's as simple as that. Mycetoma. Love these. Okay. All right. Girls want to stop or want to continue? We are at page 8. There are a lot of pages for head and neck, so we can continue this week, the whole week. Unless like Wednesday, Dr. Nora Katabi is going to give us a salivary gland like kind of session of the slides, and those will be from back presenter as well. And Tuesday, Dr. Aki is going to show us the pancreatic slides. So then we have Wednesday. So that's our, okay. So Tuesday, Dr. Aki is showing us 27, Dr. Katabi is showing us. So we have 25, 28, 29, 30, 31 to see all the head and neck slides, whatever we can. And then from 1, 2, and 3, Dr. Yersley is going to show us liver again, more of liver. So because we need more liver in our lives. And then 4, 5, and 6 we have empty. So we are going to read that from 7 onwards, we have neuropathology. So we are going to have like, I forgot the name, but she's going to show us from the MGH. She's going to show us the whole week neuropathology, more of tumors and frozen sections. And then this we can read Kurt's notes on neuropathology or something too. Do you want to read Kurt's notes at all, like for head and neck? Let's see. Kurt's notes. I mean, I agree that the path presenter is much more useful, much more useful. Let's see if we want to read the Kurt's notes at all. So salivary gland tumors, she's going to go over, but what else? And then I don't know. What do you girls think? Like, what do you guys think? Do you think that Kurt's notes are, we should continue ever, or we should just leave the Kurt's notes and just do the path presenter and go back and read about it? What do you think is more effective?
A path presenter is more interesting.
Right? It is more interesting.
Yeah.
You're getting much and much, and it just becomes monotonous. And I mean, though it is good, these notes are really good, but having that kind of session with so many slides and then reading in path outlines is really more interesting.
And maybe
Oh.
keeping this beside us when we do path presenter, we'll have a quick understanding. Like Kurt's notes along
Yeah.
with
Yeah, first let's see if how much we are able to finish in path presenter. Actually, there are a lot of slides in path presenter. If you see the head and neck, the last is 80. We are still at 8. So we have a lot to finish in path presenter too. So if we just see these cases, they're more than enough as well, I guess, because these are real-time cases and most common cases that happen. So if we see this Monday, Thursday, Friday, so today is 24, Saturday, Sunday, if we can finish the head and neck path presenter, not finish, but at least do as much as we can. And because till now we are doing this high yield cases, the high yield cases don't have a lot. We already finished the high yield cases yesterday and it was pretty fast. And I think that was effective because we are reading everything, we are learning everything. So that was good too. But now I found the slide library, which is much better because we have so many cases in the slide library. All right, so let's finish up. Let's wrap up the session. And tomorrow we are going to read from slide library page 8 again. Okay.
Sounds good. Thank you very much.
Sounds
All
good.
right.
Thank you.
Thank you,
Thank you.
Dr. Gupta.
You.
Yeah. Thank you. Thank you. Bye-bye. Thank you.